What advice do you have for mentoring new ICU nurses? Another question from the tribe asking for some advice. This time we have a preceptor who's interested in some tips on precepting or teaching the new nurses in the ICU. And this is interesting. I've never actually had this question. You would think that this would have been a common question. But interestingly enough, I had to go searching. And lo and behold, no one's ever asked for advice on how to precept a new nurse. Always got the new nurses asking questions, new NPs asking questions, but nobody's asking questions on how to be a good preceptor. Both interesting and maybe a little disappointing. But nonetheless, let's get started. I thought of 10 things. I decided to whittle it down just to 10. So let's go with just 10. Number 1, never ever forget where you came from and what it was like to be that nurse that you were precepting. Never forget the fear and the anxiety that you had when you were first starting out in the ICU. How absolutely terrifying it was to start. It doesn't matter if you started as a new grad or if this was your second or third job as a seasoned, experienced nurse. When you start in the ICU, you have the deer in headlights, eyes wide open, mouth open, and you are just flabbergasted at the amount of information that you are required or expected to know. That amount, so you need to have the empathy when the going gets tough, because you're going to get upset as a preceptor. You're going to lose your cool. You're going to get frustrated. You're not going to take the time necessary because you're going to get exhausted. Being a preceptor is exhausting. So I want you to remember what it was like to be that new nurse when things get tough. Number 2, we all learn differently. Everybody learns more efficiently in a different manner. I've talked about it before, the Vark Method, V as in visitor, V-A-R-K, the Vark Method of learning. Google that stuff. It has everything to do with, are you more of a visual learner, auditory, reading and writing? I don't remember what the other one is, to tell you the truth. I probably should have did my research, but, you know, that's me. The Vark Method talks about what's the best way for you to learn, which in turn would be what's the best way for you to teach something to your orientee. Something as simple as medications or interventions, all the way up to the complex equipment that they're going to have to learn to manage. ICPs, CVPs, central lines, swans, EVDs. I mean, the list is absolutely endless. And you're going to go from novice to expert, simple to complicated. But you need to remember that just because you learned it a certain way doesn't mean that they're going to learn it that way. Number 3, I want you to communicate, but not coddle. You need to effectively communicate with your orientee in a manner that is stern but endearing. And it sounds ridiculous, but you not only need to communicate effectively, but you got to make sure that you're not being overbearing, you're not being an a-hole, and you're communicating so that the orientee gets it. I'm not saying you need to be coddling and holding their hand the entire time, even though you're going to be holding their hand for quite a while. I'm not saying you should be holding their hand and patting them on the back and giving them a little tap on the shoulder and it's going to be okay. No, I grew up in the school of hard knocks. It's time for the boys and the girls to put on their big boys and big girl panties, suck it up and grow a set and develop that thick set of skin, but you also don't beat them down. Number 4, you should dedicate, if not weekly, bi-weekly updates. Every week, every 2 weeks, you and your orientee sit down and you review what happened, what went well, what went wrong, and what your action plan is. This keeps you in continuous communication with them so that they're not in the dark about what is expected of them, and you're not in the dark about what you're doing right or wrong, because this is a partnership. This is the relationship of give and take. It is not a dictatorship where you say they do. That is not how people learn. That is not how we grow our profession. Create a relationship, create an open line of communication with your orientee. At the minimum, bi-weekly sit-down meetings. And they don't have to be 30 minutes long. They can just be 5 minutes, 10 minutes, hitting the high points, bullet points. Here's what I'm thinking. What do you think? Here's what we got going on. Here's the plan. All right, see you next shift. That's simple. Number 5, set a schedule. You should know how long it's going to take for an orientee to go through the orientation process. Standard operating procedure is usually about 3 months, but every ICU is different. Some smaller, some larger. There's a 2-part internship and then an orientation. Everybody's a little different. You need to at least be cognizant and aware of what that schedule is. You do not get to show up willy-nilly and just pick something out of thin air what you want to do for the day. You need to have a plan. Number 6, even with a plan, you need to decide what is the most important. What are the things that your orientee needs to know before they get off of orientation? As we all know, you're not going to learn it all in orientation. I don't care how much you decide to cram into the 3-month process. You're not going to see it all. You're not going to do it all. You're not going to experience it all. So you need to make sure that you are hitting all of the things that you consider to be absolutely must-have. What can you provide your orientee so they provide safe, effective care in a teamwork environment? They need to learn how to utilize their resources and be able to ask for help, but they also have to be able to navigate and manage their caseload, their patient load. What is it they need to know? For instance, maybe you don't spend as much time on teaching them the inner workings of a balloon pump if they don't see a balloon pump very often. Now, if you work in a cardiac unit and you see balloon pumps every day or 2-3 times a week, okay then, there you go. You got to spend more time on them. But maybe you don't see balloon pumps, or maybe you don't see swans. Maybe you don't see EVDs and ICP monitors. Pick and choose what is the priority. I'm pretty sure vasopressors and managing shock should be a priority because shock is standard of care in the ICU. Ventilator management, the basics of ventilator management, pretty sure that should be a priority because the difference between the ICU and just about everywhere else, ventilators. Enough said. Number 7. Send them to other people. Send them to other preceptors, other nurses, other leadership, other colleagues. Send them to anyone else so that they can see how it's done another way. Your way is not the only way. Your way may not be the best way. Your way might actually be the wrong way. Just because you're a preceptor doesn't mean you're infallible and always correct. You're going to screw up. You're going to make mistakes. There are a lot of things that you probably suck at. So if you suck at it, make sure that you send them to someone that sucks less. Okay? Number 8. I think you should dedicate an entire shift to them just doing traveling. Traveling as an ICU nurse is a skill that we all fail to practice. And it sounds rudimentary and simple, but the very best nurses can travel efficiently with their patient load. Being able to manage packing the patient up, traveling to wherever you got to go, giving them to the scan, doing the scan that you need to. MRI is obviously a little bit more challenging than CT. Being able to manage that effectively and efficiently, not only as the nurse, but coordinating that with your respiratory therapist and your transporters and the department that you're going to. I think you should dedicate an entire day to them just traveling so that they can start seeing the common challenges that you're going to expect when you're traveling with a patient. Because as we all know, fit usually hits the shan when you're traveling. How many of us out there have had to code a patient in a neighboring department, down in CT, down in X-ray, down in MRI? How many of us have had to code a patient in the elevator? You need to make sure that your orientee is prepared for that. I would probably recommend doing this whole traveling thing early in their orientation when they're just with one patient, or they're taking care of a patient that is low acuity. Number 9 kind of goes along with the traveling concept. I think they should spend an entire day or spend a series of days responding to all the codes. They should respond to all the condition A or C or code blue or whatever the heck you call it in your facility. I think they should spend an entire day just responding to conditions, to the cardiac alerts. Maybe you have a code team. Tack them onto the code team, let them go with the code team for the day or for a set half a day. So for the first several hours of their shift, their code team, or at the end of the day, or on a night shift. I truly believe the only way they're going to get over their fear of cardiac arrest, conditions, code blues, is to throw them into the frying pan and have them experience it firsthand and get their hands dirty. Obviously under a supervised environment, best case scenario, because they're going to be scared, they're going to be freaked out, they're going to be with people that can help them and be their resources. Expose them early so that when they get out there on their own, they're not as afraid and they're a lot more efficient and a lot more useful to the team. Number 10, this last tip is for you, the preceptor. I need you to have the self-awareness and the common decency to realize that maybe you suck as a preceptor. I don't care how much pride you have and how much passion you have to teach the next generation. There are some people out there that just aren't good teachers, that they just stink. They're awesome and are the best bedside nurses. They're the kind of nurses you want on your floor. They're the kind of nurses that should be in leadership. For some reason, they can't communicate effectively. They can't communicate and teach someone else a concept, at least not in an effective and flexible manner. There are some nurses out there that are hardwired to just be the go-getter, to be the person that gets things done, instead of being the preceptor that has the leash and lets the new nurse go a little farther each time, or to be that mother hen that lets the chick kind of go as far as they can before they reel them in. There are some nurses that don't handle that well. I don't care how many years you have under your belt. There are some nurses that are not meant to be preceptors. And you should have the self-awareness and the common decency to realize when you stink at it. Because if your orientee is struggling month after month, or if you have orientees that struggle rotation after rotation, and you in your mind say to yourself, well, these kids just don't know what they're doing, or these kids just don't want to learn, Maybe it's you instead of these kids. So have the self-awareness, common decency to do a self-evaluation, and have somebody else who you respect, who is your colleague, maybe a provider, that can be honest with you and say, hey, you know what, Sean, you're the nurse I want taking care of my patients, but you suck teaching the others. Maybe you need to hear that from someone so that you can fix your game and be that preceptor that you want to be. Have the I keep saying self-awareness, but you need to be able to look inward and have others evaluate you so that you can be the very best educator and teacher for that next generation. Take it upon yourself to not only be the best at teaching them, but to improve your method of teaching. The very best preceptors, the very best nurses are the ones that can self-evaluate, redirect, and up their game regardless of their experience and years under their belt.